ठीक है, आ गया. Hello everyone, a very good evening, namaste, vanakkam to all of you. I am Dr. Vivek Goyal and I am here to take you back to the nephrology world where we had begun yesterday. I hope all of you are fresh, full of zest, full of gusto, as I always say, full of excitement to learn a wonderful subject of medicine, that is nephrology. Okay, I can already see a few questions from yesterday's doubts already creeping up my chats, but I will request you to keep all those. I have answered most of the queries already, and still if there are, please continue to ask on that thread. I will answer. I did not get much time today because I just returned from the hospital now and I just changed, got freshened up, and I'm here with you. So I did not get much time there, but I will try to do it tonight if there are any unsolved queries. So I request you to all to please do not continue with your queries of yesterday's class. If you have any, I think there shouldn't be, because I tried my utmost to please you. All right. Now, yesterday I got a flurry of messages, so did Sumer sir and all the DAM's office regarding the duration of the class. I really found yesterday's class the students were so very intelligent, so very interested in my subject that maybe I got a bit carried away. I stretched your limits, so did I of mine, and I took you to a point where probably you were not comfortable with. So today I promise you, today I shall complete it early. I shall try to leave you by say 9:45 or 10 p.m. I do not commit one time because I will try to complete the topic that I will have at hand then. Alright? So I suppose all of you are fresh, ready with your cup of tea with you, and are we good to go? Yeah, so yesterday we had cleared our concepts regarding the basics of nephrology, regarding the physiology, regarding the relevant anatomy, regarding the different channels in the different parts of the nephron, and how to correlate physiology with medicine, with pathology, with biochemistry, with pediatrics, with genetics, and so on. So it was, it was really very, very enamoring to most of us, and I was really amazed to see such a lot of positive feedback where, students really said that, sir, we have studied each of them separately in separate subjects, but it was a delight to amalgamate them all and have a consolidated concept. Yeah, I really was very, very happy to see this. Some people really enjoyed that part, and I'm glad that you guys benefited. All right, now, we completed our class yesterday at this note that we ought to be hungry always. Not only in terms of tangible food, but we need to be hungry for experiences in life, for knowledge in life. Because each experience teaches us. Even if you fail, you learn, and you learn to not commit the same mistake again. And when I say stay foolish, a person said me, messaged me that, sir, is it really we should be foolish in the world to succeed? I obviously didn't mean that. By foolish, I meant do not be overconfident. When you think that you are wise, when you're too wise, you tend to close the doors of your eyes and your brain, and you're not open to learning. But when you admit that, it's okay to not know that much, it's okay to be not that smart. If you are okay with that, you are a lot more receptive. Okay? So now, as I always ask, how's the Josh? And I know a sound is reverberating inside my ears. Very high, sir. So is mine. Nothing can deter, as Sumer sir always says, that, a virus will not let our enthusiasms come down. We are the supremest human creatures on earth. And, we cannot let the tiniest particle deter our concentration and deter our determination. That's the spirit. The fallacy being that if you weigh all the viruses together, which have caused havoc in this world, in this planet, they will weigh less than 1 gram in toto. And just imagine the amount of havoc and destruction organisms weighing less than 1 gram in toto have caused to us. Okay? So, still we will not let it deter our determination to learn, and we will fight back and we will bounce back. Superb. And yes, today's quote of the day, according to me, will be work hard in silence and let your success be the noise. Okay? Let your success be the noise. Do not let your mouth do much of the talking. Let your actions speak. So will we concentrate this on our classes as well. So we will not try to type in too much. We will try to be a patient listener, because you know a very big quality of an achiever in life is a good listener. A good listener is only a good speaker, and a good listener is a good perceiver. And that who perceives well, understands well, and that who understands well ultimately wins in life. Okay? Alright? Alright? So, gearing up. Now, let's begin. So, yesterday we had completed with the physiology and clinical presentation of a nephrological disease. Now, today we shall straight away begin with investigation of nephrological disease. So we have understood ki how will a patient come to us? How will a patient present to us? With what complaints? But now, if a patient comes to us with decreased urinary output or for the urine or reddish urine or whatnot, how will I as a nephrologist or how will I as a physician approach that patient to reach a conclusive diagnosis? Alright, this is how we approach today. So today, let us begin with the topic of, I shall just tilt it a bit now. Okay. Investigation of renal disease. Now, how do you investigate renal disease? Now, the very first of all, at the very outset, what we do is very often we prescribe a kidney function test. You know, you are very often right. We very often see doctors or physicians in the prescriptions writing KFT, blood for KFT or blood for kidney function test. So what do I mean by that? What does it include? Now usually it will have the following parameters. What does it have? It can have a urea or a BUN, that is blood urea nitrogen. It will have a serum creatinine value. It will have sodium value. It will have a potassium value. It will have calcium. It will have phosphorus. And it will have serum bicarbonate. So this is usually, these are the normal values that comprise a renal function test or a kidney function test in the blood. Now, what is the significance of each and what is the normal value of each? We should know that. Only then we'll be able to know that what is the abnormal value, right? Am I correct? Yes, very good. So we should know that the normal value of urea is 20 to 40 milligrams per dl. Now, what is BUN? BUN is basically the blood urea nitrogen. So it is basically the nitrogen part of the urea. Okay. So it is basically BUN is equal to urea by 2.14. This is the mathematical expression. So we get the urea, we divide it by 2.14, or in many cases, most of the labs do it for us, and we get the value of the bun. Now, the normal value of bun is taken to be 8 to 18 milligram per dl, approximately. The normal value of creatinine is 0.6 to 1.2 mg per dl. Sodium is of course 135 to 145 milliequivalents per liter. Potassium is 3.5 to 5.5 milliequivalents per liter. Calcium is 8.3 to 10.4 milliequivalents per liter, and phosphorus is 3.5 to 5.5 milliequivalents per liter. So these are the normal values of the different parameters that are given in the blood urea in the kidney function test. Now we should know that what is the significance of each. Only then will we able to interpret that what is the meaning of something is deterring for it. Yes, correct. Now significance is urea or BUN content. It depends on protein intake and liver function, because you know liver is the organ where the urea cycle bicarbonate is 22 to 26 milliequivalents per liter. Okay. Now, so bun or urea basically depends on the protein intake and the integrity of the liver. Alright. Now, the creatinine, the serum creatinine value, creatinine is basically a product of muscle metabolism. So it depends on muscle mass. It is a product of muscle metabolism and it depends on muscle mass. Okay. Alright. Now, sodium, it depends on the total water content. Why do I say so? Because there might be a condition where the total sodium in the body might be normal, but because the total water content of the body has increased, sodium might be appearing to be low. That is known as a dilutional hyponatremia. So actually sodium is not low, water is low, but still it shall be reflected on the sodium. That is why sodium always depends on significance, or it depends on the total water content. Okay. Now, can I move forward? I hope all of you have written with me. There is nothing very difficult to be understood here. Everything is pretty easy. Just keep writing with me. Okay? Good. Very good. Now, so we get a ratio known as bun by creatinine ratio. We get a ratio of bun by creatinine ratio. Now, normally, the normal bun to creatinine ratio is 10 to 20. The normal bun to creatinine ratio is 10 to 20. Now, depending on the bun to creatinine ratio, we usually get to understand what is the type of AKI. So, if this bun to creatinine ratio, if it is less than 20 or it is more than 40, if it is less than 20, it denotes an intrinsic cause of AKI. If it is more than 40, it denotes a pre-renal cause of AKI. Please write it down. I shall explain it again. When I shall be teaching you acute kidney injury. So do not worry at all. Do not worry. I shall again bring it up when I shall teach you. Okay? Is it clear? Is it clear? Very good. Very good. Now, so, I am so sorry, I just did a small mistake. This shall be more than 20. This shall be more than 20. Now, bun by creatinine ratio, if it is less than 20, it is intrinsic AKI. If it is more than 20, it is pre-renal AKI. Now, many of you will ask me, sir, bun by creatinine ratio is normally less than 20. So, how will it denote that the patient is having an intrinsic AKI? Because along with bun by creatinine ratio less than 20, you will also have a high serum creatinine. You will also have a high serum creatinine. What do I mean by that? Let me give you an example. Now, say if you have is there any confusion? If it is less than 20, it is intrinsic AKI. If it is more than 20, it is pre-renal AKI. So if you get a bun of say 60 and if you get a creatinine of say 1.5, you can calculate the bun by creatinine ratio and it shall come to around 40, which is definitely more than 20. So this is a case of pre-renal AKI. Is it clear? Absolutely clear? Good. Now I can see some noise in background, but there shouldn't be any noise because I've even switched off the fan, dear students. I have even switched off the fan. So there shouldn't be any confusion whatsoever. Okay? All right. It is creatinine. Just a second. Hello. Now, I just had a talk with the technical team also regarding the noise, but I have switched off the fan also. You can see I'm sweating a bit. There is just an air conditioner which is going on in the room. There shouldn't be any cause of any added noise, and I have checked it twice that my voice is clearly audible to all of you. So please try to cooperate, students. Please try to cooperate. Okay? Please try to cooperate. Now, after renal function test, what is the next thing that we have to understand? Next is calculation of GFR. The next thing is calculation of GFR. Alright. Now, how do we calculate the GFR? To calculate the GFR, we can use two methods. One is the direct method, and one is the indirect method. In the direct method, what we do is we inject a substance from outside and measure its clearance. Now, in the indirect method, what we do is we calculate the clearance of endogenously produced substances. Via equations. Please write down. I will explain it to you again. So basically, there are two methods to calculate GFR. One is a direct method where we directly calculate the GFR. We directly ascertain the GFR by injecting a substance from outside and we measure its clearance. An indirect method is that through which an endogenously produced substance ka clearance is seen and GFR is calculated via equations. So the difference here is, here it is calculated via equations and here the GFR is actually got from the clearance of the substance. Now, what are the substances that are used? What are This is the most accurate method, but this is the most used method. Now, theoretically, the most sound method is the direct method to calculate the GFR via an exogenous substance. But it is obviously not at all practically used in day-to-day life because it is very difficult to do. And what we do in real life is we measure the clearance of endogenous substances and we plot it into equations and we get the value. Is it clear? Now, what substance do we use? The substance that are used are inulin, or here endogenously metabolized we can use urea, we can use creatinine, or we can use cystatin C. So you can use inulin, we can use urea, and we can use cystatin C. Now, why are these substances chosen at all? There must be a reason that why these substances have been chosen. I told you yesterday that there are three primary physiological processes going in the nephron. One was glomerular filtration, one was reabsorption, and the last one was tubular secretion. I told you this yesterday. Now, if you carefully understand, inulin is a substance which is freely filtered at the glomerulus. It is neither reabsorbed nor secreted. So basically, what I will get in the urine is basically only a product of glomerular filtration. No reabsorption, no secretion. Whereas urea is a substance which undergoes filtration, partly reabsorbed, partly secreted. So this is at all not a good marker, because it will be hampered by reabsorption also and secretion also. Coming to creatinine, it is filtered, not reabsorbed, but it is secreted by the tubules. Creatinine is secreted by the tubules. So again, tubular secretion will hamper the calculation of creatinine clearance. But cystatin C is something which is freely filtered at the glomerulus. It is reabsorbed, but it is not secreted. So basically, if you find out and cystatin C undergoes one more process, that is catabolism by the kidney. So, if I ask you which substance amongst the four is the best to calculate glomerular filtration rate, the answer lies in the name itself. There is only one substance which is only reflecting filtration, because it does not undergo reabsorption and secretion. Hence, inulin is considered to be the gold standard to calculate GFR. It is the gold standard. So inulin is the gold standard to calculate GFR, because it is the direct method and it undergoes only filtration, neither reabsorption nor secretion. But the problem is it is very good that it is very accurate, but it's a direct method and it is not available in India. And it's a very, very cumbersome method. So we do not do it usually. Alright? So what we do usually is calculation of a GFR through indirect method by endogenously produced substances like creatinine, cystatin C or urea. Among these three endogenously produced substances also, the most commonly used is creatinine. Most commonly used endogenous substance to calculate GFR is creatinine and not the other two. It is most commonly used. Now how do we do that? We basically calculate GFR through complex equations. As I told you, we have a few equations. We have a lot many equations. What are they? Initially, we had a Cockcroft-Gault formula. Then came the MDRD formula. But the equation that is recommended right now is the CKD EPI equation. This is the recommended equation to calculate GFR. This is recommended equation to calculate GFR. Is it clear? We do not use anything else now. Okay? Is it clear? It is Cockcroft gold. Now, so this is how we use it. Now we must know that what is CKD EPI equation based on. Now many of you have been asking me, sir, do we need to memorize the CKD EPI equation? Absolutely not. Absolutely not. It is not humanly possible also. It is not humanly possible also. What do you need to do? What do we do in practice? Sir, we all have smartphones and iPhones. We all have applications and Google on our phones. So what we can do is we can just need to enter the values, and whenever we check for it, it will ask us age of the patient, sex of the patient, ethnicity of the patient, and creatinine of the patient. As soon as we plot this, we shall get the GFR of the patient. We shall get the GFR of the patient. Okay? Okay? Is it clear? Good. So these are the variables, and this was asked in one of the Central Institute examination, that CKD EPI equation is based on all except, and it is based on age, sex, ethnicity, creatinine, but it is not based on weight of the patient. This was the answer, and this is the crux, because weight can be a very big confounding factor whenever you have to calculate the GFR. Whenever you have to calculate the GFR. Okay? Alright. Alright. Now, okay? Alright, chalo. So now, this is how we calculate the GFR through direct and indirect method. Now moving ahead, we have discussed the formulas. Now, as you correctly said, that if you have to measure the GFR directly, inulin is the gold standard, but it is not available in India. So what do we do? We use radioisotopes. We use radioisotopes like we use technetium-99 labeled DTPA scan. We use technetium labeled DTPA scan, and its advantage being it is obviously a direct method, and it gives us differential GFR, that is GFR of each kidney. basically the direct method that is actually practically used in real life is using the radioisotopes. It is using the radioisotopes, but it is not the third method. It is the direct method. It is the direct method. Okay? It is the direct method, and the advantage being it gives a differential GFR. So we can actually know that each kidney is contributing to how much of the GFR. So if the GFR of the patient is say 120 ml per minute, we can know that left kidney has 60 and right kidney has 60. Or say if it has 100 ml per minute, we can know that the left kidney has 60 and the right kidney has 40 ml per minute. This is how you do it. Now, some people look a bit confused. I shall just revise this topic once again. The GFR calculation is done by direct and indirect method. Direct is via injection of a substance from outside. Indirect is from endogenously produced substances. Now, direct is most accurate, but indirect is the most used. The substances that we have are inulin, urea, creatinine, and cystatin C, of which creatinine and inulin is the gold standard because it is only filtered and not reabsorbed and secreted. Among the endogenously produced substances, the best that is used is creatinine. But again, there is a fallacy that it undergoes tubular secretion. Please remember that. Now, the indirectly when we used some equations, and the equations were Cockcroft-Gault, MD-RD formula, and CKD-EPI formula, of which the recommended equation is CKD-EPI equation, which is based on age, sex, ethnicity, and creatinine. Okay? Some people are asking ethnicity, how does it matter? See, the complex equation has a multiplication factor, and that multiplication factor is got by plotting the GFR of thousands and lakhs of patients of a particular ethnicity. So we know that if a person belongs to this ethnicity, the calculation will have a multiplication factor of X for females and Y for males, and that multiplication factor will differ from ethnicity to ethnicity. Is it clear? Because different ethnic types have different body build types, have different genetic makeup, and so on, and each of them modulate or change GFR. Is it clear? Good. Okay? Now, this is how you calculate GFR. Now, after GFR calculation, the third investigation that we are going to study today, is ultrasound KUB. Okay? Now, what do we get in the ultrasound KUB? We get whatever we get. So we must know that what we shall draw a table. What are the parameters? What is normal and what is abnormal, or the significance. So we shall study in a tabular form. Now parameter is, number one, we get to know what is the site of kidney. Now site, whatever is, it tells us about the position. Abnormal is ectopic kidney. But do remember that an ectopic placed kidney does not necessarily mean abnormally functioning kidney. Ectopic kidney can have normal function. Please remember this, that an ectopic kidney can have normal function. Clear? Is it absolutely clear? Now, हेलो, नहीं ब्लैक हो गया पूरा. नहीं, मेरे फोन में तो नहीं आया वो तो. Yeah, I am very sorry for the technical glitch. I am very sorry for the technical glitch. Do not worry, all of you are grown-ups. You can very well understand that in a live class, a small glitch can occur. Okay? So do not be so perturbed. Do not be so perturbed. Okay? Now, next is, what else does an ultrasound tell us? What else does an ultrasound tell us? The size of kidney. The normal kidney, a normal kidney has a size of 9 to 12 centimeter. Has a size of 9 to 12 centimeter in adults. Is it clear? Now, what if this is abnormal? What does it signify? What does it signify? The significance is, if the size is less than 9 centimeter, it means that the person is having a small kidney. If the person is having a small kidney. Now, if that small kidney is unilateral, or if the small kidney is bilateral. Now, if the small kidney is unilateral, it can mean that the patient can have renal artery stenosis. Very, very important. Very, very important. Yes, USG KUB is kidney, ureter, bladder. If the kidney is bilaterally small, it denotes chronic kidney disease. It denotes chronic kidney disease. Is it clear? Is it clear? Good. So, if the kidney is unilaterally less than 9 centimeter, it denotes renal artery stenosis. If it is bilaterally small, it denotes a chronic kidney disease. Now, if the kidney has a size of more than 12 centimeter, more than 12 centimeter kidney means large kidney. Means large kidney. What do you mean by large kidney? If the kidneys, a large kidney is unilateral or it is bilateral. If it is unilateral, it can denote hydronephrosis, or if a kidney is bilaterally large, it denotes autosomal dominant polycystic kidney disease. It can be there in diabetes mellitus. It can be there in amyloidosis. It can be there in HIV. or infiltrative disease like lymphoma. So this is what you mean by a large kidney. Very important, you must understand. Yes, a congenital small kidney will also be there. See, there can be numerous causes, but I am only writing the very important ones and that which are important for MCQ purpose. Okay? And that which are important for MCQ purpose. So you have understood that what are the causes of unilateral and bilateral small and large kidney. Clear? Unilateral small kidney will be renal artery stenosis. Very good. Is it clear? Absolutely clear. ADPKD means autosomal dominant polycystic kidney disease. Good. Very good. Now, so we have understood the site of the kidney, the size of the kidney. The next parameter that we must understand is corticomedullary differentiation. Corticomedullary differentiation. Clear? Which is known as CMD. Now, in normal circumstances, CMD is preserved. But if the CMD is lost, it means CKD, chronic kidney disease. But in AKI, it can be preserved. In acute kidney injury, the CMD can be preserved or is preserved. So, can CMD be used as a parameter to diagnose acute kidney injury? Absolutely not. Because a patient of acute kidney injury will have a normal CMD just like a normal person. But yes, it is used to differentiate between AKI and CKD. It is used to differentiate between AKI and CMD, and this was asked in PGI Chandigarh. This is the question of PGI Chandigarh, that what parameter in the ultrasound, or what is the differentiating feature between acute kidney injury and CKD, and the answer is CMD is lost in CKD but it is preserved in AKI. Is it clear? Good. Now, moving ahead. After corticomedullary differentiation, you can also get a new parameter which is echogenicity. What do you mean by echogenicity? The normal echogenicity, yes, it is preserved. Now, if the echogenicity is the kidney is usually hypo or isoechoic with liver. So what do you mean by that? That is the echogenicity, that is the shadows of the kidney are very similar to that of the liver. But if the echogenicity increases, but if there is increased echogenicity, it denotes it is sensitive to renal disease, but not specific. Is it clear? I hope I am clear. I hope I am clear. So if you have a patient whose USG report shows that the echogenicity is increased, what idea will I get, sir? Sir, I will only understand कि इस patient की kidneys में कोई problem है. What problem is there? Sir, I do not know. It is only a sensitive but not a specific. Sir, are you definitely sure that the kidneys are defective? No, sir. Absolutely not. For that, you get a renal function test done. Is it clear? Good. Next. Moving on. Symmetry. This will answer most of your questions. Symmetry. Normally both are equal. Normally both the kidneys are equal and symmetrical. But if you get an asymmetry of more than equal to 1.5 centimeter, it can denote renal artery stenosis. Renal artery stenosis. This is a very important question. This is a very important question. Is it clear? Now, so if the kidneys are asymmetrical by more than equal to 1.5 centimeter, you will get, it means renal, it can be a marker of renal artery stenosis, because sir, very simple sir, if one kidney artery is stenosed sir, so it is not getting enough blood supply sir, and if it is not getting enough blood supply sir, it is undergone ischemic degeneration sir, and the kidney will shrink sir. But the normal kidney is normal sir. Now many of you are asking sir, अगर bilateral renal artery stenosis होगा तो क्या होगा? Both kidneys will shrink. That's called the CKD. Over bilaterally shrunk kidneys. So equal. Simple. Okay? Good. Now, next. Let us see the collecting system. Now, in the collecting system, we always see if it is dilated. If the collecting system is dilated, it can denote obstructive uropathy. It can denote obstructive uropathy. Is it clear? Very good. I hope I'm absolutely clear to all of you. Good. Now, so this is about the ultrasound kidney bladder. That is, we see the site of the kidney, the size of the kidney, the position of the kidney, the symmetry of the kidney, the collecting system in that, and the corticomedullary differentiation and the echogenicity. Out of here, the very important questions are from the CMD, where it is preserved, where it is lost, what are the causes of unilateral and bilateral shrunken kidney, and what do you mean by asymmetry of the kidneys. If it is more than equal to 1.5 centimeter asymmetrical, say one kidney is 10 centimeter, one kidney is 7 centimeter. So you know that it is asymmetrical by more than 1.5. It means that that kidney which has a smaller size is probably having an ischemic injury due to renal artery stenosis. Clear? Good. Good. Collecting system is dilated, usually a urological entity, that the patient will go to a urologist. The patient can have a hydroureteronephrosis or a hydronephrosis also. But that patient will not come to me. That patient will usually go to a urologist. And I hope, my dear students, that you guys know what is the difference between a urologist and a nephrologist. I hope you know that. Nephrologist is a physician of the kidney. Urologist is a surgeon of the kidney. Nephrologists are those who are very smart, who wear an apron, who wear a stethoscope around their neck and do not want to dirty their hands much. And urologist is that जिसके and urologist is the surgeon, and you know the basic essence of a surgeon. Dr. Saurabh Dixit must have taught you the SX gene. Surgeons are those जिसके हाथ में अगर खून न लगे, if they don't have blood in their hands, their food doesn't digest. So you know it's a very very typical difference of personality and traits between a physician and a surgeon. You know, you can understand by their, you know, walk only that who is a physician and who is a surgeon. A physician, you know, how no matter how successful he is and everything, he will be a very, very humble, a very, very docile, a well-behaved character. And surgeons, as you all know, they are full of swag. They are full of swag. Okay? And on the lighter note, I know a surgeon, you know, he only does piles and anal fissures, but still he walks with such a swag that is, you know, immeasurable. But you know, this is off the record. Please don't convey it to my surgery counterparts. I don't want to get their beating, okay? Dr. Dixit is a very good friend. So please, I don't want to bear the brunt. Alright. Okay? Now. So, now, after we have completed this, what else will we do? What is the next investigation that we shall study? Now, next, what we shall do is, we shall do a renal biopsy. We shall do a renal biopsy. Okay? Now, when do we do a renal biopsy? We usually do a renal biopsy, which is basically the gold standard investigation. Obviously, no beta. Collecting system is obviously not dilated normally. It is normal normally. But if it is dilated, it can show a obstructive uropathy. That is what I have said. I hope I am clear now. Okay? Renal biopsy is the gold standard. You know, in Hindi there is a saying, pratyaksh ko praman kya? So you know, if you have basically, what do you mean by that? That what is evident in front of your eyes, needs no subsequent proof. So basically, if I cut a piece of the kidney and show it to you under the microscope and show it to you, ki sir, dekhiye, this is the diagnosis. Obviously, you will not ask me for more. That is the best method. That is the best method. So, renal biopsy is the gold standard. Now, what are the indications of renal biopsy? The indications of renal biopsy are nephrotic syndrome, nephritic syndrome, systemic diseases, with renal dysfunction, okay? All right. Now, so we are basically discussing the indications of renal biopsy, and I see certain messages that, you know, my voice is not clear. I hope my voice is absolutely clear. Is my voice clear to all of you? Yes. Thank you very much. Thank you very much. Yeah. So these are the normal indications of renal biopsy. That is a nephrotic syndrome or a nephritic syndrome or systemic diseases with renal dysfunction. Yes. Very recently, Dr. Srinath must have taught you. The diseases like SLE or vasculitis, where we do a kidney biopsy. I hope. Yes, absolutely correct. Very good. And last but not the least, if we get a renal transplant dysfunction. So if a patient has had a renal transplantation and if his creatinine suddenly rises, of course we need to do a renal biopsy, because we will suspect maybe it could be a rejection. It could maybe a rejection of the transplant. Okay, so we will do a renal biopsy immediately. Is it clear? So these are the indications of renal biopsy. Is it clear? Absolutely clear. Now, so these are the indications of renal biopsy. And the last but not the least, the very important investigation of nephrology, I have skipped till now purposely because I want to discuss it. I wanted to discuss it at length, that too in the evening, and that is urine examination. Urine examination. Please pardon me, urine, for having discussed it in the last, because I wanted to discuss it in details. That is urine examination. That is urine examination. Is it clear? Good. Now, what are the different parameters that we see in urine examination? Number one, the different parameters of urine examination are: number one, the color of urine. The color of urine. And you must know what is normal. So normal is blank, normal is colorless or straw colored is normal urine. Now if a person has straw colored or colorless urine, that is normal urine. Is it clear to all of you? Is it clear to all of you? Okay? Okay, I'm so sorry. This is the fifth one. Clear? So, if a person has colorless or straw colored urine, that is basically the normal urine. Now, what are the different colors that could be pathological and could indicate a disease to us? The colors that could be: if a person has black colored urine, if a person has black colored urine, and yes, my biochemistry champions, you are correct. Black colored urine is seen in a disease known as alkaptonuria. And please revise your biochemistry that alkaptonuria is due to the deficiency of dash. Dash enzyme causes alkaptonuria. Okay? Next, the opposite of black, which is my favorite color, but which I never hope to see in my own pee, that is white. White color urine is seen in A. filariasis, B. trauma, C. renal cell cancer, can be seen in renal tuberculosis. These are the four conditions where you can get white colored urine, and white colored urine is also known as chyluria. And this is an old PGI Chandigarh question, multiple correct type, where the question was chyluria is found in dash, and the options were filariasis, trauma, RCC, TB, glomerulonephritis. And you know that the correct answer is these 4, and if you mark all the 4, you get a +4. You get a +4. Clear? Good. Now, after black and white color, let's discuss orange colored urine. Now, orange colored urine is very important. If you are a resident of India, say for example, you are a doctor who has done his MBBS and MD in India, and who has prescribed, who has consulted a patient living in India who had an Indian disease, and on your Indian prescription you wrote Indian drugs and sent the patient back home. 7 days later he calls you back on your Indian landline or on your Indian mobile and tells you, sir, I am having orange colored pee. Sir, I am very, very anxious. Why am I saying Indian so many number of times? Why am I saying India? I am saying India so many number of times in this regard because if you are a doctor in India, if you do not know Wegener's granulomatosis, it is okay. If you do not know Buerger's disease or Cogan syndrome, it is more okay. But if you do not know one disease, no matter you are a pulmonologist, no matter you are an ENT, no matter you are a medicine physician or you are a orthopedician, आपके जीवन में बहुत दुख है if you do not know this disease. And the disease I am talking about is, yes, the disease which is synonymous to India, that is tuberculosis. And why do I say so? Because it is caused by a drug which is the first line drug to treat tuberculosis. Absolutely correct. The drug is rifampicin. The drug is rifampicin. Is it clear? Next, if a person has red colored urine, red colored urine, very, very important. Where can it be found? Red colored urine is found in number 1, hematuria. Number B, hemoglobinuria. Number C, myoglobinuria. And number D, not so a pathological cause, that is beet root ingestion. Is it clear? Absolutely clear. Good. Superb. So these are the different colors of urine which are very, very important. RCC means renal cell cancer. Clear? Good. So these are the different colors of urine that are very, very important. Now, after the color of urine, the next important parameter that you must know is specific gravity of the urine. That is the specific gravity of the urine. Very, very important. The specific gravity of the urine. Now, a question was asked in one of the All India entrance examination that how is specific gravity measured? Specific gravity is measured through a process known as refractometry. It is measured through a process known as refractometry, and the normal specific gravity is 1005 to 1030. This is the normal specific gravity. Is it clear? Very good. Now, very important, if I ask you, sir, what do you mean by specific gravity in simple terms? What do you mean by specific gravity? Many of you must be thinking, sir, if we knew this much, why would we be sitting here, sir? This was so much of physics, sir. Itna aata, sir, so we would have been sitting in some multinational corporate companies after completing our IIT and whatnot, sir. But don't worry, you are here because you have correctly opted so. Don't look at your friends who are already settled and doing jobs or stuff like that. If they are, trust me, you are at a much better position than them, because you are doing the thing that you always wanted to be and you are passionate about. So never ever undermine yourself, never underestimate the power of a common man, never underestimate the power of a doctor. You can do wonders and you will do wonders, okay? It is just that the incubation period that we require is a bit longer, not much, bit longer than your other counterparts. Is it clear? So specific gravity is basically weight of any substance by weight of water. अगर मैं और सरल शब्दों में बोलूं तो it is basically how much, I mean, what is the weight of the substance? So if something is heavier, in crude terms, if something is heavier, has a higher specific gravity. If something is lighter, has a lower specific gravity. Now you can very well consider urine to be a solution that has a solute and a solvent. The solvent in the urine is basically water, and solutes are the metabolic waste products. Absolutely clear. Now मान लो if the water content of the urine increases, so solute will decrease. So can I say that basically the weight of the urine has become lighter? Yes or no? Is it clear? So basically for your urine to become light, two things can happen. A, the water content can increase, or B, the solute content can decrease. Is it clear? So if your water content in the urine is increasing, it can either mean two things. A, you're drinking more water, or B, you are excreting more water. Am I clear? Am I clear? Yes or no? Yes. Now come to the opposite. If the specific gravity increases, it means the weight has increased. It can either occur by two things. Either the solute content has increased, or B, the water content has decreased. Now if the water content has decreased, it can mean two things. That A, you are drinking less water, or B, you are excreting less water. Am I clear? Yes or no? If it is clear, the things are very easy now. Now let us write down. Let us write down. So the specific gravity of the urine can be, just a second, the charging one just gets, yeah. So the specific gravity of the urine can be increased, can be decreased. When the specific gravity increases, it is known as hyperstenuria. Hyper means more, sten means specific gravity, urea means urine. When the specific gravity decreases, it is known as hypostenuria. Now I told you, if the specific gravity increases, it can mean two things. Either it can mean you are drinking less water, or you are excreting less water. Now if you are drinking less water, that means you are dehydrated. Or you are excreting less water. And I taught you yesterday that there is a condition where a hormone increases so much in the body that you excrete less water in the urine and you retain water in the body, and that condition is known as SIADH. SIADH. Is it clear to all of you? Now Now, no beta, the decimal is not missing. It can be expressed in different units. Is it clear? Yes. Clear? Now, if the specific gravity of the urine has decreased, it means it is hypostenuric. When I say hypostenuric, it means what? Either you are drinking more water, that is, the patient has polydipsia, or you are excreting more water, that is, you have deficiency of a hormone that reabsorbs water, that is diabetes insipidus. That is diabetes insipidus. So you can just see that these two are actually the antonyms or the opposites of each other. Clear? Now, what if there is a third entity? Now the third entity can be if the specific gravity is fixed at 1010. If the specific gravity is fixed at 1010, what do I mean by that? Now, why do I say 1010? Why do I say specific gravity fixed at 1010? Now, as I told you yesterday, if you have to explain the function of a kidney to say a 5-year-old child, that kidney ka kya function hai, what will you say? In simple terms, you will say that beta, kidney's function is to excrete metabolic waste products in the form of urine. Now, मान लो kidney is failed, kidney is not functioning due to any process, then what will happen? If the kidney does not function, the kidney will not excrete the metabolic waste, and if the kidney does not excrete the metabolic waste, the urine will not be concentrated. Now see, the urine is concentrated compared to blood because it has a waste. But if the kidney does not function only, the urine will not have the waste. And if the urine will not have the waste, urine will tell to the kidney, urine will tell to the blood, you and me same to same. You and me same to same. What is the medical word for same to same? What is the fancy word for same to same? ISO. What is the medical word for specific gravity? Sten. Urine means urea. So, this is known as isostenuria. And why did I say fixed at 1010? Because actually speaking, 1010 is the specific gravity of blood. So, actually, this blood and urine have become identical and they are telling to each other, you and me same to same. So if I ask you, which was the question asked in AIIMS, that what is the cause of isostenuria, and I told you at the very beginning that it is a condition where the kidney stops functioning. So if the kidney stops functioning due to an acute process, it can be a process known as acute tubular necrosis, which is known as ATN, or it can be a chronic process known as chronic kidney disease. Now henceforth I will be only writing it as ATN or CKD. Now you have to understand that what are the full forms of each. Is it clear? Is it clear? Very good. It is clear? Yes, if the urine specific gravity gets fixed at 1010, it is of course abnormal. It is of course abnormal. Is it clear? Good. Now after specific gravity, the next important urinary parameter that we have to study is hematuria. Is hematuria. Clear? Now what is significant hematuria? significant hematuria is defined as more than equal to 3 RBCs per high power field. More than equal to 3 RBCs per high power field in more than equal to 2 out of 3 occasions. Is it clear? Is it clear? So if you give 3 samples, out of the 3 samples, in at least 2 of those samples, there must be more than equal to 3 RBCs per high power field. I hope I am absolutely clear. Very good. Or you are saying, sir, how much effort will we make, sir? How many samples will we give, sir? Can't I have a shortcut, sir? Alright, chalo. Show me gross blood in urine. So if you show me gross blood in urine, of course, we will have no doubt that it is hematuria. Of course, we will have no doubt because it is gross blood. Clear? This is an MCQ. This is an MCQ. Now, how do we approach hematuria? Now, we approach hematuria and we divide hematuria into, we generally divide hematuria into glomerular hematuria and non-glomerular hematuria. Now, what do I mean by that? What do I mean by that? What do I mean by glomerular and non-glomerular? Now, let us have an example of each so that the concept becomes easy. An example of glomerular hematuria will be glomerulonephritis. And an example of non-glomerular hematuria will be, say, a urolithiasis or a stone. Am I clear? Say if I have to draw a schematic diagram and this is the endothelium, this is your GBM and these are your podocytes, and say this is your kidney, this is your ureter. Okay? Now say you had any glomerular disease, say a glomerulonephritis or a PSGN or an IgA nephropathy. What will happen? This is the glomerulus and inside RBCs reside. Yes, but due to the pathologic process, this barrier will get breached and this RBC will come outside. When it will come outside, it will be like this. Yes, but on the right side, you have a ureter and ureter has a stone. And the stone impinges on the blood vessel in the ureter because every vessel has a blood vessel. And this blood vessel bleeds and you have the blood here. Is it clear? Now just see the patient on the left bleeds from inside the glomerulus. Now glomerulus bleeds and the RBC comes outside from the vascular pole to the urinary pole, and does it have to face any traffic? हाँ सर, ट्रैफिक तो बहुत सारा ट्रैफिक है सर, वो भी माइक्रोस्कोपिक ट्रैफिक है, पासिंग थ्रू द एंडोथेलियम, देन थ्रू द GBM, देन थ्रू द पोडोसाइट, then through the tubule, then coming to the minor calyx and stuff like that. But here, this urine, this blood came to the ureter, ureter se bladder, bladder se urethra, urethra se pot. It did not face any traffic. Yes or no? Yes. Very good. So, if I have to evaluate both of them, what will be the morphology of RBC in both of them? The RBC morphology in a glomerular hematuria will not be the same normally because dekho, due to traffic they get deformed, and you know the medical word for anything which is abnormal is dys. and the medical word for shape is morphia. So this RBC will be dysmorphic. Yes, absolutely correct. While on the right, the RBC that is there in the urine, it is very identical to RBC in the blood. So ये RBC, what will this RBC tell to the blood and to the RBC of the blood? This will tell, sir, you and me, same to same. And what is the fancy word for same to same? Iso. What is the medical word for shape? Morphia. So this RBCs will be isomorphic. This will be isomorphic. Yes. Now, coming to RBC cast. I will teach you what is cast. Don't worry. Now, cast is very pathognomonic of glomerular injury. So, an RBC cast will be present in a glomerular hematuria, will be absent in non-glomerular hematuria. Now, when the filtration barrier will breach, only RBC will not leak. उसके साथ साथ some proteins will also be leaked. So, glomerular proteinuria will be associated with severe proteinuria or more than 2 gram per day. While non-glomerular proteinuria and non-glomerular hematuria like stones will either have no proteinuria, of course not, or if it will have less than 2 gram per day proteinuria. Is it clear? या तो होगा ही नहीं और होगा भी तो it will be very very low. Very good. Now, if I ask the patient or say what will be the MCV of urinary RBC? The MCV of the urinary RBC. So if I see the mean corpuscular volume of urinary RBC in glomerular hematuria, because it is deformed, it has a face-to-face a lot of traffic, it will get crenated, and this will usually be less than 72 femtoliters. It will be less than 72 femtoliters. Clear? But in non-glomerular hematuria, the MCV of urinary RBC will be equal to MCV of blood RBC. मतलब सर अगर ब्लड में माइक्रोसाइटोसिस है देन यूरिन में माइक्रोसाइटोसिस है, अगर ब्लड में मेगालोब्लास्टिक अनीमिया है तो यूरिन में मैक्रोसाइटोसिस है. सो वॉट एवर बी दैट इन द ब्लड you will be that will be reflected in the urine also. Is it clear? Very good. And a very important difference which I told you yesterday also, beta protein is usually when a filtration barrier will breach, there will be holes in the filtration barrier due to inflammation. Only RBC will not leak, protein will also leak. That is, there will be significant proteinuria here. Whereas on your right, there will be no proteinuria only. But if at all there will be, it will be less. Okay, and I will teach you what kind of proteinuria that is. Don't worry. Last but not the least, color of urine. Last but not the least, color of urine. The color of urine, if it is a non-glomerular hematuria, usually it is reddish or pinkish because it is coming from lower down. But if the cause is glomerular, it is usually altered and usually the color is cola colored or brownish colored. I hope I am clear. I hope I am absolutely clear. So देखो how important is a routine urine examination, because say if a person comes to you to your clinic tomorrow and says, sir, I am having reddish urine, you ask him what is it? It is bright red or is it brownish red? Cola colored, sir, brownish red. Go to a nephrologist. Bright red, go to a urologist. Please get me a urine RM done. I will get a routine urine done, and routine urine I will look for dysmorphic RBC and casts. If it has dysmorphic RBC and cast, it is basically glomerular hematuria. If there are isomorphic RBC and no cast, it's a non-glomerular hematuria. You do know that certain important autoimmune diseases can have glomerulonephritis and can present with glomerular hematuria, and they can be very, very devastating. But for a stone will not kill you in a day, unless in a very grave circumstance. So if a patient asks you, sir, when do I go to the doctor? Just now or tomorrow? You can be like, okay, go to according to your convenience, according to your symptoms, but tomorrow also bhi chal jayega. But glomerular hematuria, usually you say no, go to him right now. If a patient goes there and if the nephrologist sees the amount of RBC and the casts, he can understand the gravity of the disease. So he can then decide whether he has to admit him or make an OPD, treat him OPD in OPD. So just see, a plain routine urine examination can tell you so many things, that where the bleeding is coming from, whether to go to a urologist or a nephrologist, and whether to treat him in an OPD or to admit him. This is the beauty of routine urine examination. Okay, routine urine examination is literally that goggles that enables a nephrologist to look inside the kidney of a patient without actually entering into it. This is the beauty of routine urine examination. Is it clear? Next. After hematuria, next is proteinuria. Now normally urinary protein is less than 150 milligrams per day. So normally एक इंसान के यूरिन में less than 150 mg per day protein is found. Out of the 150 mg, less than 30 milligram per day is albumin, and rest 120 are non-albuminuric proteins. You will ask me, sir, what are the non-albuminuric proteins which are present in the urine? And they are TAM horsefall protein, they are IgA protein, beta 2 microglobulin, and urokinase. So these are the proteins which are normally found in the urine, and this was again asked in a PGI Chandigarh exam. The question was, all are found in normal urine except, and the students, most of them, they did not know that TAM horsefall protein, IgA protein, beta 2 microglobulin and urokinase are also found in normal protein, normal urine, mind you. Is it clear? Is it clear? Very good. Very good. And I used to not remember it because I was not as intelligent as all of you until last year or the year before. I saw a Hindi movie. I'm quite fond of it. I know most of you are very intelligent. You don't watch Hindi movies. And it was a suspense thriller where the protagonist unscrupulously throws out a elder woman out of the window, and the man was pretending to be blind. Was he not? Was he yes? In the end, I also don't know the answer, and I don't know if you know the movie, you've guessed the movie's name or not, but there was an actress in the movie which was this, and I tend to remember the name of the non-albumin protein through this mnemonic. So it is TABU, or taboo or taboo or whatever you would like to call it. Is it clear? Good. Very good. So this is normal proteinuria. And what are the types of proteinuria? Now, how do you approach proteinuria? Just like anatomically we had approached hematuria into glomerular and non-glomerular hematuria, we approach proteinuria into 4 types, that is glomerular, tubular, tubular, overflow and postrenal. So these are the 4 types of proteinuria which is basically the anatomy and pathophysiological classification of proteinuria. Now what do I mean by that? Now I will just be tilting it a bit, okay, so that I can write comfortably. Now, what is the mechanism of glomerular proteinuria? The mechanism is of glomerular proteinuria is increased glomerular filtration. The mechanism of tubular proteinuria is decreased tubular reabsorption. The mechanism of overflow proteinuria is increased production of low molecular weight proteins. And the mechanism of overflow of postrenal proteinuria is inflammation in urinary tract. So basically, just concentrate here. One is a disorder of glomerular filtration, one is a disorder of reabsorption, one is a disorder of production, and one has inflammation. Is it clear? Is it clear? Clear? So these are the mechanisms of different types of proteinuria. Now, what is the main protein here? The main protein in glomerular proteinuria is आपका अपना सबका albumin. The main protein in tubular proteinuria is beta 2 microglobulin and TAM Horsfall protein. The main protein in overflow proteinuria is वही जो पूरे देश में है. आपको यूरिन में you will get that only which is prevalent throughout the country. And I am an apolitical person. I mean Benz Jones protein. Please do not take me otherwise. Please do not take me otherwise. Is it clear? And when I'm talking about inflammation in the urinary tract, what do I mean by that? I mean IgA and IgG. Is it clear? So these are the chief proteins in the different 4 types of proteinuria. Clear? Yes, you are correct, Pooja, not in Kerala though, and I am happy it is not there because leave it is not doing something that one should be happy about in the current scenario, but you and we both are still waiting for अच्छे दिन. Okay? So, and of course I was talking about Benz Jones protein. So I do not know what you all are talking about. Okay? So I'm absolutely ignorant of the things that you are talking. Alright. Now, coming to amount of proteinuria. Amount per day. Now, glomerular proteinuria, as I told, is usually more than 2 grams per day, but in all the three, usually the proteinuria is not that severe and it is less than 2 gram per day. It is less than 2 gram per day. Is it clear? TH is tam horsefall protein. TH means tam horsefall protein. Now, talking about caste. Caste is definitely pathognomonic of glomerular proteinuria. Can be present in tubular proteinuria, maybe not. May or may not be present in overflow proteinuria, but will never be present in post-renal proteinuria. I hope I'm absolutely clear to all of you. I hope I'm absolutely clear to all of you. Now, to understand this better, can you give me some causes of glomerular proteinuria? Can you give me some causes of glomerular proteinuria? Yes, you are correct. It is basically the glomerular diseases like glomerulonephritis. It could be diabetes mellitus, can be amyloidosis. Can you give me the causes of tubular proteinuria? Can you give me the causes of tubular proteinuria? It could be hypertension, could be Wilson's disease, a disease. A patient came to me with, a 16-year-old male came to me during my second year of medicine residency, and the patient had come to me with a dystonic posture like this. And when I took the history, when I inquired, he was also mentally retarded, and there was a history of seizure disorder also. Now, while evaluating dystonia, when we routinely evaluated him, I saw gross abnormality in his liver function test. And when I got an ultrasound done, liver was shrunken. And when I got a history, in detailed history, he also said that there was a history of melena also. So basically, the patient also had a chronic liver disease. So a patient of chronic liver disease with Wilson's, a young patient with no alcoholic history, I immediately thought of something and I got a ophtha examination done. And can you tell me what I got in my ophtha examination? Yes, I got my Kayser-Fleischer ring, and I made the diagnosis of Wilson's disease. Absolutely good. This is how, these diseases can integrate many subjects of medicine and can present to you. Next, there can be lead poisoning. And I told you yesterday something, global PCT dysfunction. Global PCT dysfunction is known as Fanconi syndrome, when it will cause dysfunction of the PCT, proximal convoluted tubule, T for tubular. There will also be tubular proteinuria. Very, very important. And all these are questions. Yes, I know the class, I think there's a problem there, and I will get it uploaded, don't worry, today itself. Coming to overflow proteinuria, can you tell me a disease where there is excess production of proteins in the body and where there is BJP in the urine? You are correct. The answer is multiple myeloma. Absolutely correct. Can you tell me a disease where, the name itself is saying post-renal, meaning beyond the kidneys. What is there beyond the kidneys? The urinary tract. And if there is inflammation, there could be UTI. There could be UTI. So, in UTI, there could be an inflammation, and inflammation can lead to exudation of IgG, IgA, and that can lead to proteinuria. I hope you are absolutely clear? Very good. This is how you approach glomerular, tubular, overflow and post-renal proteinuria. Now please understand one thing. Every topic or every question from glomerular and tubular has been done and dusted. It has been asked in every exam n number of times. But overflow and post-renal are still virgin topics because it is not there in Harrison only. So please write down, this is very important for exam point of view, because your examiners usually don't change the topics. They ask newer things from the same old important topics. So my guess is overflow proteinuria and post-renal proteinuria is going to be asked very soon in your exams. Please write it down. Very, very important. Very, 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 very important. Is it clear? Beta 2 Mg means beta 2 microglobulin. Globulin. Clear? Last but not the least, urinary albumin to urinary microglobulin ratio. Now, urinary albumin to beta 2 microglobulin. These examiners, they very well know that mathematics is definitely our strongest subject, right? Maths is our strength? No, sir. If maths would have been our strength, then we would have been solving some other equations, sir. But why are we stuck here with ratifying things? I know maths is not your strength. I was trying to be a bit sarcastic. But because it is not your strength, they tend to formulate equations out of simple things and they tend to confuse you. Now, 2 or 3 years back, they formulated there's a ratio of urinary albumin to beta 2 microglobulin ratio. And you must know that normal ratio of urinary albumin to beta 2 microglobulin is 50 to 200. Okay, this is the normal ratio. Now just see, if in glomerular proteinuria there is more of albumin, so if the numerator increases, the ratio increases. So I was taking this class in Lucknow. I think I did a mistake by mentioning the center, and I went on that the numerator increases, so this and a girl was looking at me blank, and I asked her, beta, what happened? She said, sir, numerator किसे कहते हैं? I didn't say a word. I said the numerator is the ऊपर वाला number, denominator is the नीचे वाला number. Okay, so basically in this ratio, glomerular proteinuria, the numerator will increase, so the ratio will increase, so the ratio will be more than 1000:1. In tubular proteinuria, the urine will have more of beta 2 microglobulin, so the denominator will increase, so the ratio will decrease. So the ratio will be less than 10:1. And of course, in दोनों में the ratio does not matter, not be counted. So this is a very important question, and this is an X all India question. This is an X all India question, urinary albumin to beta 2 microglobulin ratio. Please mark it important. Clear? So this is how we approach proteinuria into 4 headings. Now, after this approach, there is another type of an approach to classify proteinuria, and that is called selective proteinuria versus non-selective proteinuria. Sir, what do I mean by that? Very simple, beta. Selective proteinuria is very much like girls. Girls are very, very selective. They will excrete only albumin. And non-selective proteinuria is like boys. I am also of your community. I don't want to mock anyone. I am just on the lighter note. Okay. So basically, Non-selective proteinuria includes not only albumin, albumin तो है ही, but साथ में क्या है? It has TAM horsol protein, it has IgA protein, beta 2 microglobulin and urokinase. So please repeat with me the full form of TABU. T means TAM horsol protein, A means IgA protein, B means beta 2 microglobulin and U means urokinase. Atul Ram Prasad Yadav, it does not matter because उन दोनों proteinuria में albumin and beta 2 mg are not there. So why will the ratio be calculated at all? Is it clear? Is it clear? So this is selective and non-selective proteinuria. Now, can you give me an example of non-selective proteinuria? So selective proteinuria is found in minimal change disease, which is abbreviated as MCD. And non-selective proteinuria can be found in focal segmental glomerulosclerosis and membranous glomerulonephritis, which is abbreviated as MGN. So these are the causes of selective and non-selective proteinuria. Now again, equation has come to confuse you, and this was asked in a central institute examination question. This was asked in a central institute examination. Urinary IgG the question was urinary IgG to transferrin ratio. Is it clear? Is it clear? Now you must understand that weight of transferrin is half weight of IgG. This is the background that I am telling you. So basically, you have understood that if I calculate the ratio of urinary IgG to urinary transferrin, transferrin has a lower molecular weight, that to half of that of IgG. So basically, in a disease which has selective proteinuria, that will only allow lower molecular weight proteins to pass through. Yes or no? So in a selective proteinuria, there will be more of transferrin, and transferrin, because it is the denominator, the ratio will decrease. So if this ratio is less than 0.1, it denotes selective proteinuria. If this ratio is more than 1, it denotes non-selective proteinuria. I hope I am clear. I hope I am clear. T for TAM horsfall protein. FSGS means focal segmental glomerulosclerosis. Is it clear? This is a all India question. Very, very important, mind you. That urinary IgG to transferrin ratio is lower in selective and it is higher in non-selective proteinuria. I hope I'm absolutely clear. Okay? Now, so we have understood what are the different proteins in the urine. We have understood how to divide them anatomically. We have understood how to divide them based on selectivity. Now, very important, how do we detect proteinuria? To detect proteinuria, you can either have number one, dipstick method, which is the classical method which we use in our wards also, medicine wards. dipstick method? Yes or? So dipstick method का एक very important thing is it detects only albumin. Dipstick method detects only albumin, but it might so happen that your patient has proteinuria but does not have albumin in his urine. So how did this? So for example, a patient had come to me with say a pedal swelling, and there are three causes of edema. It could be a renal cause, it could be a cardiac cause, or a hepatic cause. I ruled out hepatic and cardiac cause, so I knew it was a renal cause. I was suspecting a renal cause of edema. So I got a urine routine examination done, and routine urine examination showed protein absent. But still, I was suspecting a renal disease. So what I did, I got a 24-hour urinary protein done. And to my surprise, 24-hour urinary protein showed 2 grams of proteinuria. So what did I learn? I learned that urine में protein तो है, but albumin नहीं है. I'm repeating once again. I understood that it is not albumin because it is not detected by dipstick. Because dipstick की fallacy is it only detects albumin. So I understood there must be some method to detect any protein which is not albumin also. And then I came across a method which is known as sulfosalicylic method. Sulfosalicylic acid, it detects albumin plus non-albuminuric proteins. So the advantage of sulfosalicylic acid test is it can detect every proteinuria, not only albumin. Is it clear to all of you? Very good. Now, dipstick method also has a few more fallacies which are very favorite of AIIMS. It can have a false positive or a false negative. Now I know all of you are champions of PSM and you can give me lectures on false positivity and false negativity, but me being a physician, PSM was never my strength. Though I somehow managed to get a gold medal in PSM, that's a separate scene. So when you get a false positive means actually it is not positive but you are getting a positive, and when you say false negative it means actually it is not negative but you are getting a negative. That's what I understand. So false positive means that actually there is no albumin but you are getting a positive test. When can that be? It can happen in cases of number 1, hematuria, concentrated urine, or alkaline urine. So you can get a hematuria or a concentrated urine or alkaline urine. But if you get a false negative, can you tell me one false negative cause? Already I have mentioned it. Where there is protein but it will not detect. Yes. Number 1, non-albuminuric proteinuria. Clear? So if I ask you true or false, dipstick method will detect the proteinuria in Wilson's disease. Sir, I know Wilson's disease causes tubular proteinuria and tubular proteinuria does not have albumin. So will it be detected? No, it will not be. Answer is false. So it's a false negative. And number 2, it does not detect, false negative is albumin less than 300 mg per day. So today I understood a very important thing. I understood that we were thinking that dipstick is only loyal to albumin. But no, we got to understand something more कि ये albumin का भी सगा नहीं है because it will not detect albumin less than 300 mg per day. That is, it will not detect. I will teach you now that 30 to 300 is microalbuminuria, so it will not detect microalbuminuria also. So it is not even totally loyal to the one protein it detects. So can I say now, if I have to tell you that what does dipstick detect in one way, in one line, one sentence? Sir, dipstick detects only albumin more than 300 mg per day. Beautiful. This is the complete answer. I hope it is absolutely clear to you. It is absolutely clear to you. Is it clear? Good. So after detection of proteinuria, let us now understand how do we quantify proteinuria. How do we, I will just tilt it a bit. How do we quantify proteinuria? Okay, to quantify proteinuria, we have a method that is 24-hour urinary protein estimation, and we have a method which is urinary protein creatinine ratio, or albumin creatinine ratio, which is abbreviated as PCR or ACR. These are the two methods that we have for quantification of proteinuria, and you can very well understand this is the gold standard or the best method. This is the best or the gold standard method, and you also know that usually the best or the gold standard methods are very, very difficult to do. They are very, very cumbersome. Sir, why it is cumbersome, sir? Because आपको patient को ये बोलना है that ma'am, you please take a jar. From today 8 a.m. in the morning, tomorrow 8 a.m. in the morning, whenever you pee, ma'am, please pee in this jar. Patient will tell you, sir, I went to the market to get some groceries, sir. There I had an urge to pee, sir. I peed there. What will you tell her? No, you can't pee there. Of course you can pee. And again, your sample will not have, it's not a complete sample. So 24-hour urinary protein estimation is a difficult test. It's a best test, and we do it when we have any confounding factor of certain diseases. But usually what we do, we take a spot urine sample and we calculate the protein creatinine ratio. That is, how much protein is excreted with respect to the creatinine in the urine, and we can extrapolate it to get the holistic view of the entire day, and we can understand how much is the protein lost by the kidney. Is it clear? So, protein creatinine ratio or albumin creatinine ratio is the most preferred method. I hope you can remember a very similar terminology we can use in GFR also. In GFR the gold standard was inulin, but the preferred was creatinine. Here the gold is 24-hour and the preferred is PC ratio or PCR or ACR. So you have to create analogies and keep correlating medicine. This is how you study and correlate medicine. Is it clear? Good. Now, when you quantify proteinuria, what are the values that you can get? The values that you can get are, you can have a proteinuria from 30 to 300 mg per day. It could be from 300 to 3500 mg per day, or it will be more than 3500 mg per day. Is it clear? Now, don't worry students, I am here with you. I will just take some more time. Please bear with me. I hope you all will. Clear? Now, this 30 to 300 mg per day was previously known as microalbuminuria. (300 to 3500 mg per day) is known as macroalbuminuria. Whereas more than 3.5 grams per day is known as nephrotic range proteinuria. But mind you, this was the old terminology. The KDIGO has replaced these terms with newer ones, though it is still used. But the newer terms in vogue, which have also been mentioned in your 20th edition of Harrison are, microalbuminuria is now known as moderately increased proteinuria. Macroalbuminuria is now known as severely increased proteinuria, and nephrotic range proteinuria is still known as the same. So micro becomes moderately, macro becomes severely, and nephrotic still known as nephrotic range proteinuria. I hope I'm absolutely clear. Yes, it is milligram per day. Now one more thing, I just missed telling you all that albumin creatinine ratio or protein creatinine ratio is expressed in what units? So it is albumin is milligram and creatinine is gram, so it is mg per gram of creatinine. So this is the unit of ACR or PCR. So if we say 300 mg per gram of creatinine or 30 mg per gram of creatinine, is it clear? So this can be correlated with 30 to 300 mg per gram of creatinine, 300 to 3500 mg per gram of creatinine. If I have to mention the albumin creatinine ratio, and this will be more than 3500 mg per gram of creatinine. I hope I am absolutely clear. Okay, so we were discussing micro, macro and nephrotic range proteinuria. Now without wasting any more time, please write down the causes of microalbuminuria. Okay, causes are: number 1, early diabetes mellitus, early hypertension, early glomerulonephritis. So if I ask you the causes of macroalbuminuria, you will tell me, sir, आज का जो अर्ली है वो कल तो लेट होगा, आज का जो माइक्रो है वो कभी तो मैक्रो बनेगा. सो macroalbuminuria is 1 plus 2 plus 3 and what? Number 4 is fever. Number 5 is exercise. Number 6 is heart failure. Number 7 is myeloma. And number 8 is very, very favorite of examiners, postural proteinuria. And I know many of you are already very, very surprised and very, very amazed to hear these three causes. You are saying, sir, fever, sir, exercise can cause macroalbuminuria. Chalo, I have given you one more reason to not exercise. Though, I have also not been able to do right now because of a very busy schedule. That's not an exercise, that's not an excuse, because time is never, got. Time is always taken out. That always, my mentor used to tell me. And you never get time, you have to take out time. So, it is milligram per day, not microgram. Milligram per day. Sure. So these three causes were fever, exercise and heart failure. Why is it important? Because in तीनों में the kidney is not at fault. Kidney is just bearing the brunt of somewhere else. That is why this is known as functional proteinuria. So, fever, exercise and heart failure where kidney is not at fault but still you are having macroalbuminuria, that is a functional proteinuric state where kidney is not at fault but still it is bearing the brunt. Now, what are the causes of nephrotic range proteinuria? And you very well know they are, sir, diabetes mellitus. Sir, because diabetes mellitus, has to be paid a lot of reverence by a nephrologist. Because, if diabetes was not there, most of the nephrologists would be sitting at home. Okay, why? I will tell you in the subsequent classes. Next, after diabetes mellitus, what else can cause nephrotic range proteinuria? Can anyone tell me? It is glomerular diseases like MCD, FSGS, MGN, etc. etc. What else? MCD, FSGS, MGN. And last but not the least, can you tell me the last condition that can cause nephrotic range proteinuria? The last condition is very, very important, and let me tell you my clinical experience. What I saw this patient, this patient was admitted in my medicine ward for evaluation of anasarca. And anasarca, obviously you evaluate proteinuria, and you will be amazed that I was aghast at seeing the urine report. The urine report said the patient was losing as high as approximately 25 grams of protein per day. I had never ever seen such a report. I was totally, amazed at how can a person lose so much of protein. While evaluating him, while evaluating his pallor, I asked the patient to open his mouth, and I saw a weird finding in his mouth. I saw that both the lateral, that basically his teeth, his tongue had a lot of indentation marks. So both sides of the tongue had marks. I asked my mentor that, sir, why is it so? Why is it so? Sir said, Vivek, you are not clearly noticing. Please see that he has a huge tongue. Because he has a huge tongue, the tongue is not being able to be contained inside the oral cavity. So it is interposing between the interteeth space. And that is why there are marks. So basically, the patient had macroglossia. This was again news to me. Then I saw the patient was, sitting like this and he was walking like this. He was walking like this as if he was a bouncer of a discotheque. He had huge shoulders and he said, sir, बहुत pain है यहाँ पे. He was a thin fellow, but these shoulders were, very well big, like padded. As if he was wearing a cricket pad here. And then later on I came to know that that is one of the shoulder pad sign. So इस एक disease ने मुझे इतने सारी चीजें सिखाई. It taught me that it can have nephrotic range proteinuria, it can have macroglossia, and it can have shoulder enlargement, which is known as shoulder pad sign. You are absolutely correct. The disease is known as amyloidosis. That is why I say medicine can never be learned just by studying books. Because when other people were busy mugging MCQs, one patient came into my life and it taught me so many beautiful things. And I can never forget. I can never forget this. Is it clear? So this is the beauty of clinical medicine. When you see a patient, observe him, trust me, you will never forget it. Our teachers give examples of a patient seen 20, 50, 30 years back. And in a very small career, we also don't forget to forget patients that we have seen a few years back. Clear? Good. So this is about the different types of proteinuria. Now, one thing which is a favorite of again AIIMS, All India and all the other exams is this topic. What is this, sir? I will tell you 4 lines which are MCQ points. I will tell you 4 lines, each of which is MCQ point. What is that? Postural proteinuria is seen in young males. It is usually less than 1 gram per day. It is less than 1 gram per day. And what happens? There is proteinuria on standing. There is proteinuria on standing. So basically it is a proteinuria on upright posture. So there is proteinuria in upright posture and there is low proteinuria in lying down. Because it is posture related, it is also known as postural proteinuria, and because it is on standing or upright position, this is known as orthostatic proteinuria. Very, very important. Very, very important. Is it clear? Is it clear? Last but not the least, it is a benign condition. And this is very, very important for next exam. अब next हो या अगला हो या पिछला हो, whichever exam it is यार. Name is not important, exam is important. जो आएगा हम देंगे. Okay? Clear? So it happens in young males, less than 1 gram per day. Proteinuria is on standing, so it is orthostatic proteinuria, and it's a benign condition. So if a question was asked in JIPMER examination that all are true about postural proteinuria except, you will advise renal biopsy. True or false? Sir, you told me, sir, patient को मैं बोलूंगा घर जाओ और बत्ती बुझा के सो जाओ. Please go switch off the light and sleep. Because it is a benign condition. So why will I need a renal biopsy, sir? Go home and sleep. Is it clear to all of you? Is it absolutely clear? So do not worry. I hope I am absolutely clear. Clear? Now I can see that most of you are already worked up and you want chutti. But I will be taking your 5 more minutes. So, before I will just show you a few photographs. Can you follow this? Are you with me? I told you that if you have a case of glomerular hematuria, like glomerulonephritis, you will have dysmorphic RBC, which can be seen on the left. You can see RBCs are of different shapes and sizes. Can you see this? All of different shapes. Whereas on the right, you can see the RBCs are all monomorphic. They are all of same size and shape. So it denotes a non-glomerular hematuria. It also known as isomorphic, meaning you and me, same to same. Good. This is an RBC cast, which I shall teach you in the next class, when I will be teaching you types of cast. An RBC cast, as you know, is pathognomonic of glomerulonephritis. RBC cast is very, very pathognomonic of glomerulonephritis. Okay? Good. Rest of the cast I will show you tomorrow. Do not worry, all these I will show you tomorrow. Achha, this question we can we take this? This was a question that was asked in AIMS May 2016. AIMS May 2016. You can already answer this question, though you do not know 2 options till now. I have not taught you B and D. B and C. Forget it. Forget B and C, just look at A and D. All are true about microalbuminuria except microalbuminuria is not detected by dipstick method. I told you this. Microalbuminuria is not detected because dipstick detects only albumin, which is more than 300 mg per day, and you know micro is 30 to 300 mg. That brings me to the answer. Answer is A, because A is wrong. A is not 20 to 200, it is 30 to 300. Very good. So answer is A. Is it clear? Next. Wow. This was a PGI question, mind you. And you know PGI Chandigarh gives questions which are multiple correct. Now I asked you, tubular proteinuria are seen in. Let us write down what is seen in what. We know everything now. Multiple myeloma mein we have post-renal proteinuria. Wilson mein we have tubular proteinuria. Lead poisoning mein tubular. Fanconi syndrome, tubular. Answer is B, C, D. B, C, D plus 3. You know, in PGI Chandigarh, what is evaluated is not the number of questions, but the number of correct responses. Each response has a +1. So you get +3 in this answer. So just imagine how many thousands of rank will you just sweep if you mark this answer to be correct. Is it okay? Rest of the things I will. Acha, this question. Let me see who can answer this question for me. It is just a revision, students. You already know a lot of it. A 21-year-old man presented with dipstick proteinuria, which is an routine urine insurance. You know, insurance gives you a routine test done. He was asymptomatic which is not a cause of proteinuria. Heart failure, just remember, many people are doing in the mind, sir beach wala, sir middle wala. Yes, that wo bhi chalega. Heart failure was of macroalbuminuria and that's of functional proteinuria. So ये है, एकदम है, cause of proteinuria है. Exercise, so sir, I told you sir, don't do exercise because you have functional proteinuria. High BP, hypertension, of course. Hypertension will lead to glomerular damage, tubular interstitial damage. It's a cause of tubular proteinuria. Yes, it will cause to proteinuria. Absolutely. Orthostasis. I told you, sir, when a person stands, his BP falls. That is known as orthostatic hypotension. When a person stands, he has protein in the urine. That is known as orthostatic proteinuria. This is also there. High protein diet. Sir, all the gym freaks, so many non-vegetarians, they consume so much of protein, sir. They will eat egg also, fish also, meat also, red meat also, everything. And me being a vegetarian, for me, protein is equal to paneer and paneer is equal to protein, sir. Or soya bean or dal, sir. Poor me, lucky you all. So high protein diets are proteinuria? Not at all. If a person does not have a pre-existing renal disease, high protein diet does not make any difference. So 3 is the answer. Answer is 3. Very good. And with that, I would like to conclude today's class. And the parting note for today I will give you is I can, I will, end of story. To all your critics, to anyone who has ever challenged your ability to do anything in life, it could be your parents, could be your friends, could be your neighbors, though your loved ones, they only critique you for your positivity. Or it could be your ex-girlfriend or ex-boyfriend. Tell them, I can, I will, end of story. In fact, you need not tell them. You have to tell it to yourself. The day you will believe this, that day miracles will happening. Miracles will start happening. You know, miracle is only awaiting to happen for your own realization. The day you realize things, that day everything will happen. Because you are the supremest being, you are a part of God, and you can do everything. Okay? With that, I wish you all a lot of good sleep. Sleep tight. Try to revise all my notes. I shall be back tomorrow with a lot more nephrology. And with each passing day, it shall get only more interesting. And love you all. And again, I shall start a thread. You please give me all the comments that you have, all the feedback. If you liked anything, you disliked anything, please do give it to me. Okay? And all the best. See you.